if you fail to offer coverage to all employees and at least one employee receives a subsidy for a plan purchased in the exchange. You may have 40,000 employees. If one person, and you don't offer coverage to 1,000 of them, one of those people gets a subsidy through an exchange because of their income level, you now have a $2,000 penalty for all 40,000 folks. This is obviously an incentive to cover your entire workforce, and that's how it's structured. Now, if you offer coverage, but the coverage is not affordable, you're subject to a penalty of $3,000 annually for each FTE for whom such coverage is unaffordable, and that is defined as premium exceeding 9.8% of income or an actuarial value of 60%. The difference here is that penalty is only assessed on those individuals for whom the plan is unaffordable. So going back to the example, if you had, you offered health insurance to all 40,000 of your workers or all 40 of your workers or whatever it is, and it was unaffordable to 10, it would be 10 times 3,000, not 2,000 times your entire workforce. And interestingly, or importantly, these penalties are non-deductible. So when you're thinking about what are your costs of health care, generally those tend to be deductible. These are not deductible. All right, tax credits for small businesses. For 2000 through 2013, tax credits of up to 35% of the cost of health care will be available to small employers with 25 or fewer FTEs and average wages of $50,000 or less, who cover at least 50% of the premiums of health insurance for their employees. These credits are increased to 50% in 2014, but only for coverage purchased through an exchange, and these credits may only be claimed for 2 years. Medicaid expansion. Medicaid will be available now to all persons, including working adults, for the first time, with incomes up to 133% of the federal poverty level. That's $14,000 for an individual and up almost $30,000 for a family of 4. There'll be a temporary increase in federal matching funds to help states cover this. So, who's going to be covered under the new law? There'll be about 10 million more folks covered under commercial coverage in 2014 and about 15 million in 2019. And this will primarily be exchange-based individual coverage, at least according to Congressional Budget Office estimates. The other big group of folks that will come under coverage will be Medicaid, and that will add about 10 million in 2014 and 16 million in 2019. Let's talk about insurance market reform. Plan design and benefit design reform. Most of what I'm going to talk about will affect almost all insured and also self-insured plans. In September 2010, no lifetime benefit limits or unreasonable annual benefit limits. So no lifetime limits and no unreasonable annual limits. No rescissions of policies absent evidence of fraud or misrepresentation. No exclusions for pre-existing conditions for children, not adults yet, just children. And plans must continue to cover children through age 25. That all became effective September 23rd, but interestingly, it becomes effective for plan years beginning on or after. So many of you probably are on January 1 plan years. These requirements are not in effect today. They will be, however, in effect for your plan on January 1. January 2011, plans must maintain a medical loss ratio. Again, another term of art, but this is the portion of premiums used to pay plan benefits. Must be at least 85% for large groups and 80% for small and individual plans. If you've been reading the papers, this area has gotten a lot of attention lately, and a lot of insurers are complaining that they're not going to be able to meet these requirements, and the White House and HHS are thinking about some waivers. January 2014, no pre-existing condition exclusions for adults. Coverage waiting periods limited to 90 days. Coverage must be available on a guaranteed issue and renewal basis. So if you're a small employer, your insurance company can't say, well, we've decided not to insure you anymore. They must offer you a policy the following year. No annual benefit limits. Premiums may not take into account gender, health status, or disability, meaning no experience rating anymore. Premium variation based on age limited to 3 to 1, yay for old people, and limits on annual deductibles. Also, no lifetime or annual limits on specific benefits deemed to be essential health benefits. So, if O&P is, as expected, deemed to be an essential health benefit, there'll be no annual limits on those benefits. Now, improving quality. Just a few selected highlights. We're going to have a new nonprofit patient-centered outcomes research institute, which is going to prioritize and perform research comparing clinical effectiveness of medical treatments. Findings are to be widely disseminated, but limits on use of on their use to deny or limit health coverage. And $2.5 billion in federal funds will be raised directly from the Treasury, but also in fees on health plans over the next 10 years to pay for this. There's also going to be a national health care strategy developed by the Secretary of Health and Human Services on the delivery of health care services to improve health care outcomes and patient-centeredness for all populations. The first strategy is due in January, and the Secretary will be required to make annual updates. All right, bending the cost curve, what we were all been waiting for. Medicare and Medicaid savings, $455 billion over 10 years, 196 from fee-for-service savings, 136 billion from Medicare Advantage, 36 billion from disproportionate share payments, and 87 billion from other sources. Medicare updates. For O&P, I'm sure you're all familiar with this. You, as well as virtually all provider groups, now have an annual productivity reduction, which is likely to be in the 1% to 1.5% range each year. We have a new MedPAC on steroids, an independent payment advisory panel or board, 15 members, develop proposals to reduce per capita Medicare spending if projected increases exceed a CPI-based inflation target. As you know, medical inflation has so far exceeded CPI that it's difficult to imagine that this is not going to occur. First proposals, if required, will be due in January of 2014. These proposals must be implemented by Health and Human Services unless the Congress passes an alternative set of reductions that meet the same spending goals. And there is a proviso that the proposals may not ration care, raise Part B premiums, or change benefits eligibility or cost sharing. So it's going to be interesting to see what this board comes up with.